1.
Good afternoon. I'm Pat Living with the Department of Health and Social Services and moderator for the COVID update for Tuesday, May 26th. Today, the Chief Medical Officer of Health, Dr. Brendan Hanley, will provide a technical briefing on modeling to respond to the many questions we have received around what modeling is, what does it tell us, and how is it done. At the end, we will go to the phone lines for questions from reporters. We will call you by name, and you'll each have one question plus one follow-up. Our French-speaking journalists are encouraged to ask their questions in French. With us today is André Boursier from the French Language Services Directorate to translate those questions for those who do not speak French. Thank you. Dr. Hanley?
Thank you. Merci. As mentioned by Pat, I'm going to give a little bit of a background to the modeling and to what we are thinking as we are doing the modeling. Ce sera en anglais, donc je peux répondre aux questions en français après, mais la présentation sera en anglais. So I'll stick to English only for the technical briefing, but I'll do my best to answer questions in French after the presentation. Now, I want to just set the context that this is really about the process of models, the types of models, and the purpose of models. And some of the figures I'll be showing are examples of what models can tell us. And so it's really more about the process rather than the numbers themselves. Any number I show is going to be subject to, is based on a variety of assumptions and is subject to variability. But I think it'll help to illustrate the possibilities that we can work with when we're doing modeling. This is simply a graph of the numbers of cases, just to set the basic context. As you all know, we remain with 11 cases. We have so what we have towards the right side of the graph there is the green picture, which represents all 11 cases recovered. So if we were to project that through the rest of May, it would show just the green bars at the same level. So this is one way of portraying totals, active cases, which here are represented in orange, and then recovered cases. So models are mathematical tools, and they help us understand disease progression under various conditions. They're not predictions of the future, but they're really best guesses, as I say, based on a number of assumptions. So not every model is appropriate to answer every question at every stage of the outbreak. They're a means to estimate and predict what might happen in different scenarios. And they enable us to see, for example, what may have happened if we had not implemented public health measures and border controls at a certain point, and that's one of the areas that I'll go into for illustration purposes. In the quotation on the slide, it just emphasizes that models describe a range of possibilities, and ideally these are possibilities sensitive to action, so we can see, well, if we did this, then this might happen. In terms of the building process, modeling starts with identifying a question, and that question might be something like, how many hospital beds will we need in case of an outbreak? And then it's choosing the most appropriate method to answer that using the type of model that's best suited to answer that question. And then it's building that model or adopting a model that's already created by experts. And in our case, those experts might be in another jurisdiction, especially a larger jurisdiction that has that technical modeling capacity, or the Public Health Agency of Canada. And then we collect the data to feed into the model, run the model and analyze the results, and then repeat the process. So we started by building our own models in Yukon, relatively simple models. And now we're exploring the possibility of using more complex models developed by national organizations and other jurisdictions. Modeling is never finished, as you'll see. Even when we previously gave results based on one type of model, we now have slightly more refined results based on a more sophisticated model. We run many different scenarios, and we're continually trying to improve the model and improve the inputs and improve the outputs. I'm going to talk, although there are several types of models, I'm going to talk about two principal models that are most relevant to us. And those are called compartmental models and agent-based models. Compartmental models are simple models, and they really address population-level questions. They represent the population in various compartments, and I'll give an example of that. And they rely on an exponential growth rate of an epidemic. So that growth rate is defined. We define it by using different variables. And these models are most suitable and best applied in areas with community transmission. And that's the type of model that you will have seen applied in some of the provinces when they've presented their modeling data, especially those where they have had evidence of community spread. The other type of model is called agent-based model. These are much more complex models. They need a lot more computational power. They're much more difficult and complex to develop and to validate. And they are based, rather than on a population per se, they're really based on an individual level that then starts at the bottom and builds up to then predict population effects based on individual behaviors. So really what goes into that type of model is the individual behavior plus interactions of individuals within a population. And really what we try to get at in that model is how small changes in behavior and interactions may influence disease transmission. So the first type of model then that I talked about is the compartmental example. And in this model called the SEIR model, that has four components, four compartments, and the S stands for susceptible, so who is susceptible to infection, exposed, the number of people exposed within that population, the number who actually become infected, and then the number who are recovered. So this model, as I said, it depends on an assumption that disease is already spreading in the community. And this model uses data from other countries and from Canada and from Yukon to model how the spread would look of COVID in Yukon. It assumes a well-mixed population. It assumes individuals are equally likely to encounter each other. And it assumes that everyone stays in their own compartment, whether mild disease, severe disease, or critical case status, based on assigned percentages. It also assumes that individuals do not isolate and remain infectious for an entire period of a 7-day period. It also assumes that people who have recovered are now immune and don't become reinfected. So if we look at a number of different scenarios, and this goes back to some of the estimates that we had previously talked about. So this gives more of the technical background, and as I say, the model which we're using now will have different numbers because it's a slightly more sophisticated model with new numbers that I'll show you. So you've probably heard of the R0 value or the R0. And in this, what this diagram shows is that one person, in average, if there are no public health measures, based on average estimates of COVID transmission, one person is able to on average, transmit infection to an average of 2.5 or 2.4 other people. So again, that assumes no case identification, just free-flowing within the population, no contact tracing, no quarantine, no self-isolation from out of territory. So here you see then if a case were introduced at day 1, as you see on the left of the graph, the blue shows the number of accumulated cases that would have occurred after a period of 66 days. And that 66, again, an arbitrary number, but it was originally the number chosen when we were looking at initial infection in mid-March. How would that look in mid-May, or approximately 2 months later? So that would show us an accumulated number of cases of 2,000, almost 2,000 cases, of which on a particular day, at day 66, there would be 639 active cases. That would be documented. So that means number of confirmed laboratory tested cases. So that in turn could mean as many as 77 cases by that day requiring hospitalization and 23 cases requiring intensive care. So clearly enough to be more than what our healthcare system could sustain, even if we were to downplay some of those estimates of proportion requiring hospitalization, proportion requiring ICU. You can see that there would be tremendous pressure on the healthcare system. So our previous model, where we talked about that 7,000 number of active cases, is now slightly down revised to about 6,400. Again, small differences in numbers. The overall effect is the same, but you see that the peak is also different. So we. On the left side, you show the kind of the old peak with the older model that we used compared to the new peak. Again, running into many thousands of potential active cases based on one introduction with no public health measures. Now, the old model here is the SEIR had different assumptions, and what it assumed was that a person exposed to COVID became immediately infectious, whereas we know that it actually takes several days. So the addition of the E in the formula stands for exposed, has that factor of a lag time between the time between when a person is exposed and when they become infectious to others. Now, in the second scenario, this would be if a case similarly were introduced, and we have during 2 weeks we have that ability of the person to circulate and infect others, and those people would infect others. Again, at that 2.4 rate, one person infecting an average of 2.5 others. And then after 2 weeks, public health measures were implemented. And that would mean case isolation, case identification, isolation, contact tracing, followed by physical distancing. We would expect a lag time of about another 14 days before we could get that down, that R0 down to a ratio where it's less than 1. So that one person is able to infect less than one other person. So then the effect, as expected, would be much different. So in this case, the number of cumulative cases would be substantially lower, 67 cases over the same period of time, with up to 4 cases on any one time. So you can see that even even if we had a lag time between introduction and implementation of public health measures, it still would have had a profound effect on reducing by about 100-fold the number of infections. In the third scenario, then we have a case where it's likely what is most represented in the Yukon case, and this is the best scenario in cases in terms of disease transmission. And here the diagram shows one person affecting only about half another person, so already less than one person per person infected. So less than one, if the R0 or that infectivity is less than 1 to 1, then we know that we're in control of the epidemic. So this is built on the assumption of 0.62 more people infected for every person infected. In this scenario, the public health measures are high physical distancing, high case identification and isolation, high contact tracing and quarantine, and high self-isolation by out-of-province travelers. So that really shows that we would be in the situation which we are now, the containment, the case containment, which is again where we want to stay. It also shows that between scenario 2, so again back to the scenario 2, where there are COVID cases, but substantially lower compared to the unrestrained, and the scenario 1 where we really got ahead, there's going to be some ability potentially to adjust your risk or your risk tolerance based on the best, perhaps, balance of risks. So ideally, we would be able to model what can we tolerate in terms of COVID transmission at the cost of this amount of restriction, and start to play with how much restriction can you get away with to maintain reasonable control and prevent serious outcomes associated with your COVID. So that really comes to the role of the more sophisticated models. And these are models that don't rely on the premise of community spread. So these are really needed to better model potential epidemics. Given we managed to control our first epidemic without community transmission. So we're really looking for models that are more realistic to what our actual situation is. So we're partnering with the Public Health Agency of Canada to run various models with different degrees of public health measure relaxation. So thus, one of the areas that we're interested in is being able to more systematically assess the risk of importing new cases from outside Yukon. So that means if, for instance, in the rest of Canada, the prevalence of COVID is at a certain number, and if we have an estimate of how many people are coming into Yukon and from what parts of the country or at what rates, then what would that mean for importation and then the potential for COVID spread within Yukon? And that's where we can start to explore models that are based on individual behavior, which really should be closer to Yukon's current reality. And that's the role of the so-called agent-based modeling. So that's a work in progress. We don't have results from agent-based modeling. That again is a collaboration with Public Health Agency of Canada. Like many other jurisdictions, are relying on the computing power and the expertise at Public Health Agency of Canada to help us with these more sophisticated modelings. So it's quite clear, even without modeling, of course, but the modeling helps the simple models that we've developed so far allow us to show, again, to give us some estimate of what could have happened without any public health measures. What I think modeling can do from here on, as we get better at doing this, as we build our own expertise, as we build the collaboration with public health agency, and as they in turn start to build models based on what we know about COVID and COVID transmission, then we can get to a better place. I hope to be able to use modeling to help us balance COVID prevention with prevention of unintended consequences. Clearly, though, public health measures, including the Safe 6, are going to be important in the weeks and the months to come. We know they're effective. We've shown they're effective. The modeling data shows us the effectiveness of public health measures, and that's the way we need to continue. In an ideal world, again, we would be able to separate those measures and to know the relative contributions of each. And again, that's beyond the power of these basic models that we've been using so far. So it really gives us the overall package result without giving us the individual contribution of each particular measure, which of course would be of interest. So that's the short summary of the modeling and the type of thinking that we're putting into models, a bit of a snapshot of the progress to date, and where we hope to go with agent-based modeling in collaboration with Public Health Agency. I hope in weeks to come to be able to bring more information and more, mathematical information to help us in the weeks to come as we contemplate our ongoing reopening strategies. We also are going to be looking at things like what happens if there's a resurgence of COVID in Canada, the second wave, and how would that affect our importation risk? How will varying prevalence of COVID within Canada and varying border measures, how can we play with those variables to have a better estimate of what the risk would be by different measures of COVID circulating, and then what could we best be able to tolerate and to handle in terms of risk. So I hope that gives you a better sort of technical background to the modeling data, and I'll be happy to take some questions.
Thank you, Dr. Hanley. We'll go first to Tim from CKRW.
Hi, good afternoon, Dr. Hanley. You had mentioned that this was the model from mid-March to mid-May. What models are we looking at now? How far are you looking ahead in the modeling that I assume is going on right now?
So it's not so much of a time span as looking at different variables and different possibilities. So that goes back to the purpose of the agent-based modeling. It really looks at everything in a completely different way. And so in terms of if we had this prevalence in Canada, what would the importation risk? It's almost like we're changing the questions, because I think we've looked enough at what could have happened if we didn't do anything. I think we sort of answered that question. We're really looking to the future, which is based on so much of what we've done has been and accomplished has been around closing the borders and reducing our importation risk as close to zero as we can manage. And now we really want to say, well, how is that risk changing? When importation risk changes, then how much can we tolerate, for instance, loosening some of our border restrictions? And so it's not so much of looking at a time span, it's looking at what would the result be, and that might be a result over the weeks to come.
Next question, Tim.
I'm just wondering, with personal services businesses getting set to open, well, I guess tomorrow, restaurants on Friday, I guess How are you feeling about this, considering where we are at in the territory, and how many applications have you approved?
Well, I can't tell you how many applications. I know we've had lots coming in. I know in terms of the personal care services, I believe the last time I looked, well over 30, and I can't tell you how many restaurant applications, but I can get back to you on that. We're doing everything in a pretty secure state right now because our borders, we remain with closed borders except to essential visits, and those clearly outlined purposes, and along with the self-isolation period. So really what I'm talking about is phase 3 thinking. So how confident can we be about loosening our borders and knowing as best as we can the best estimates of scenarios associated with border loosenings.
Thank you.
Thank you. We'll move now to Jane at CBC.
Hi, Dr. Hanley. Scenario 3, it says Yukon, it has the implementation of public health measures before the first case, which seems to be what we have done. But why are there no other future projections associated with scenario 3 like there are with the other 2 scenarios? No future projection of how many cases there could be in Yukon as we continue along. Why is that not included?
Yeah, it's a really good question, and that's because, and maybe I didn't make that clear enough, and it's really because we've been applying these models that are based on community spread. So you could only really make future projections based on that model if you had ongoing community spread, whereas we have cases that are contained, and so. Really, if we think of, for instance, one case coming in tomorrow or next week or in the next couple of weeks, but we continue to have these measures in place, we remain in that scenario 3 positions because we remain on top of the epidemic, having measures in place that keep the ability of one person to spread to another at less than 1. So as long as we're at less than 1, we're in containment phase, and that means we can extinguish the epidemic. So as we're looking ahead, we're really looking at again different questions basically, rather than projections of increasing cases, because we don't. It goes back to that concept of we don't really have a curve to work with here. So we're really starting to work with different questions.
Next question, Jane.
My other question is around mask use. As more businesses are opening and the weather's nice and people are out doing things. I feel like I ask about this a lot, about how do people kind of keep maintaining physical distancing and following those public health measures. There's been some questions recently around mask use. Should people be wearing masks in Yukon, and if so, when should they be wearing them?
Yeah, so and that reflects some of the, as you know, some of the recent advice from the Chief Public Health Officer of Canada, and the recommendations through the Public Health Agency, which recommend use of non-medical masks in situations where physical measures cannot be maintained. So when that space is not able, that spacing of 2 meters is not able to be observed. So, but there's also you'll notice that there's language there quite clearly that recommendation will vary by whether there is, but by the epidemiology, by how much COVID is in the community. So in a community like ours, like in Yukon, where we do not have any evidence of community circulation of COVID, then we have an exceedingly low prevalence of COVID in the territory, and no documented prevalence at all, in fact. And we are also in a situation where physical spacing is except for some very, very isolated circumstances, really quite easy to maintain. So this is not a recommendation that I'm making based on our epidemiology in our territory that we need. Now, we have added the particular circumstances in our personal care advice. We have, because to do some of those personal care services, like a haircut or nails, it really does entail broaching that 2-meter space and very close contact. But these are at the same time non-medical settings. So as an extra precaution, we advise the use of non-medical masks in those cases. But for public use, I have not made that recommendation. It doesn't mean someone is wrong to use a mask if they feel better wearing a mask. But I'm confident, based on our degree of transmission and the absence of COVID circulation in our community, that the attention really is best placed on observing physical distancing and the other Safe 6 measures.
Thank you. We'll move to Gord, Yukon News.
No questions.
Thank you. Gabrielle, Whitehorse Star.
Good afternoon. I'm wondering, how long have you had these models available? How long have you had these numbers for? Way back when we were starting to put public health measures in, did we know that one case could end up being X number of cases that we see here?
Yeah, good question again. And we didn't know. The modeling actually, although at the moment the models that I've been talking about, the compartmental model, or the more simple model, is one that is now developed locally, and you can, if you plug in different numbers, you can get an answer in 5 minutes. But it took many weeks, really 4 to 6 weeks of development to get to that point where you can plug in numbers and get those answers. So a lot goes into model development and to really figuring out how to do it, figuring out the right numbers to put in, learning more about COVID transmission. So it's these are and this particular model, that what I called that sort of phase 2 model, the SEIR model, which has the additional exposed, is really a product of the last couple of weeks that we've had that more sophisticated version of the first type of model. So yeah, really quite recent information. So we made the original decision based really on expertise, on evidence that we had accumulated, on working with other jurisdictions, on looking at international, what had been done in China and internationally, and made the best decision on the best evidence that we had at the time.
Follow-up question, Gabrielle?
Yeah, I'm wondering, so now that we're looking at these numbers, what is the value in looking back at what could have happened and didn't?
For me, the best value is that public health measures matter. And no matter what we do, until we get to a point where we are confident that we have no more risk of COVID introduction into the territory, we have to rely on the package of public health measures, and that includes the public part, the public contribution part, which is those 6 steps to staying safe, the physical distancing. And it includes the public health capacity part of being able to maintain our capacity to be able to do the case identification, the contact tracing, and to be able to then ramp up that capacity if required. So it really gives us I think it reaffirms the need to emphasize that whatever we do from here on, the public health measures are critical in maintaining the ability to do this safely.
Thank you. Claudiane, Radio-Canada.
Oui, docteur Hanley, possible de me dire, donc, vous allez vous répéter, là, évidemment, mais en quelque sorte, quelle est la grande conclusion à laquelle vous arrivez en regardant différents modèles, là?
Dr. Hanley, can you tell us what is the great conclusion you come to, or the most important one, when you look at this modeling and what it gives you as information?
Merci. Oui, ce serait bien peut-être de tout répéter si on avait le temps, mais en général, c'est que on a démontré qu'avec le premier modèle, que les mesures de santé publique sont essentielles pour nous entretenir, pour prévenir, empêcher la menace de COVID. Donc, c'est fondamental de rester sur les mesures de santé publique. La deuxième, c'est que les questions d'ici et en avant pour le futur restent sur de poser des questions différentes. Et c'est des questions de risque d'importation. Donc, mais pour ça, il faut des modèles beaucoup plus complexes. Il faut une collaboration qui est, on est en train de collaborer avec l'Agence santé publique du Canada pour développer des modèles plus complexes pour répondre aux questions plus sophistiquées que si on change les mesures sur les frontières, par exemple, comment ça change le risque d'importation des potentiels des cas. Et donc, d'ici pour les semaines qui viennent, on attend les résultats pour nous aider à faire des décisions sur les frontières.
Prochaine question, Claudiane.
Merci. Pouvez-vous me donner donc un peu plus d'exemples concrets sur ce type de questions? Vous mentionnez donc les frontières. On sait que la frontière est déjà ouverte, ou en tout cas en partie pour permettre le trafic vers l'Alaska. Quels sont les premiers aspects là, pour lesquels vous voulez avoir des réponses en utilisant ces modèles? Est-ce que ce sont les arrivées par l'aéroport? Est-ce que ce sont l'ouverture de d'autres entreprises, d'autres commerces? Quels sont les aspects que vous envisagez en premier?
So the question is about what are the most important cases you have in mind and how it can influence the modeling you have. What are the most important things that might happen in the coming weeks that would change what we see right now in your modeling?
Donc, c'est selon la prévalence de COVID dans les juridictions à côté ou dans le Canada en général, mais aussi la circulation de COVID dans les provinces à côté de nous, comme Colombie-Britannique, Alberta, et en Alaska, et dans les pays où on a les relations directes avec. Donc peut-être on a un intérêt pour les modèles. On est très intéressé par les taux de prévalence dans ces autres régions. Et non seulement maintenant, mais par exemple s'il y a une deuxième vague, si dans la saison de la grippe, si ça remonte, et qu'est-ce que ça pose comme risque, et ça c'est joué avec si on avait telle personne qui entre et tel nombre de personnes qui traversent les frontières, comment on peut jouer ça contre la prévalence de COVID dans certaines régions. Donc, c'est cette sorte de questions qu'on va, j'espère, avoir plus d'informations des modèles.
Merci, Claudiane. Julien, aurore boréale?
Oui, en fait, je me demandais c'était quoi la marge d'erreur pour ces types de modèles.
So, what is the margin of error that you can have with these models?
C'est une bonne question et ça dépend. Par exemple, on peut peut-être mettre en question chaque variable. Par exemple, qu'est-ce que la transmission du COVID et qu'est-ce que c'est les meilleures évidences pour la transmission. Donc, on a choisi 2,4 comme l'index de transmission. On peut aussi jouer avec le nombre d'hospitalisations basé sur le nombre de cas confirmés et ça peut changer avec plus d'informations. Donc, mais en général, je pense que ça va rester dans le même ordre, même si ça change par je devine hier par 10, 20, 30%, c'est pour avoir l'ordre en général des nombres.
Prochaine question, Julien?
Non, pas d'autres questions, merci.
Merci. Thank you, Dr. Hanley. Appears that that's all for today. Thank you, everyone, for your time today. The briefing for Friday, May 29th, will also take a different format. Premier Sandy Silver and Dr. Hanley will respond to questions from the general public. If you have a question you would like to submit, please send it to covid19info@gov.yk.ca with the subject line Virtual Town Hall. That's covid19info@gov.yk.ca with the subject line Virtual Town Hall. Thank you.